Bismillahirrahmanirrahim. This is a part of our second series. We have another educational lecture for the residents, fellows, physicians in internal medicine or family medicine. Dr. Hamza Hashmi is a graduate of King Edward Medical College. And mashallah, he's now working as a faculty, as an associate professor. Is that correct, Hamza?
This is assistant professor.
Soon will be associate professor, inshallah. So he's working at the Memorial Sloan Kettering Cancer Center with his disease focuses plasma cell disorders, multiple myeloma, amyloidosis, and he's mashallah an emerging leader in the field. So without further delay, I will let Dr. Hashmi begin his talk. Thank you.
Good morning in US and good evening in Pakistan. I'm Hamza Hashmi. I am one of the assistant professors at Memorial Sloan Kettering, affiliated also with Weill Cornell Medical College. And in my clinical practice and research, I focus on plasma cell disorders, mainly multiple myeloma, amyloid, cellular immunotherapy. So very kind of you, Dr. Anwar, for the introduction and giving me the opportunity to talk about the basics of myeloma diagnosis and treatment today. Usually when I give these presentations in US, I focus heavily on cellular immunotherapy with bispecific antibodies and CAR-T. But today I am going to talk about the basics of myeloma diagnosis, presentation, treatment. We'll talk about the principles of treatment, what are the do's and don'ts of myeloma treatment. I will briefly touch upon what induction therapies we use and how we modify them based on tolerability. I'll talk about the role of bone marrow transplant, why it's a very useful tool in resource-limited settings. And we'll briefly also talk about how we treat relapsed myeloma. And then there will be some pearls of wisdom shared regarding management of complication, adjunct therapies as well. Once I finish with myeloma, I'll also briefly touch upon AL amyloidosis and share some of my clinical experience and some of the important things to remember when diagnosing and treating those patients. I will start off with a case study where a 65-year-old African-American individual presents with a month-long history of rib pain that is not relieved by over-the-counter analgesics. The patient does have tenderness in the right sixth rib region on physical exam, and the labs reveal anemia with a hemoglobin of 9.5, renal failure, and high calcium levels. Serum protein electrophoresis performed reveals the presence of a monoclonal protein, 3.5 gram per deciliter of IgA kappa subtype, and the kappa lambda light chain ratio, as we call it, the light involved uninvolved light chain ratio is more than 100. Patient gets an X-ray done for the rib lesion and found to have a lytic lesion in that area, and then subsequently goes on to have a whole body PET-CT scan performed, which shows there are multiple lesions, as you can see them on the screen, showing up on the PET-CT scan. The patient eventually undergoes a bone marrow biopsy, which shows about 80% clonal plasma cells that are kappa restricted on a flow cytometry analysis. As I walk you through my presentation, I will be mentioning this particular case time and again to show you how this case and its workup is very relevant to what we should be doing when diagnosing myeloma patients. So multiple myeloma is a part of plasma cell disorders. And all plasma cells, they start off as a stem cell in the bone marrow. They grow and mature, become B cells, and the B cells, as they mature further, become plasma cells. The plasma cells eventually become malignant plasma cells that we call them as myeloma. And as this evolution happens, what you actually end up noticing is that the B cell will lose some certain specific cell surface markers as it becomes or evolves into a myeloma cell. And those specific ones are the B cell, if you remember lymphomas, they will have a CD19, CD79 on their surface. Most myeloma plasma cells will not have a CD19 or CD79 on their surface. They, on the other hand, will have a CD56. They will have a CD38 and 138. So these are some important things to remember anytime you look at a bone marrow biopsy immunohistochemical analysis. This is a timeline for the history of myeloma diagnosis and treatment evolution. You can see the very first time we actually discovered a case of myeloma was about 250 years ago in 1855. When a young female succumbed to debilitating pain, had an autopsy done, and found a giant red tumor replacing the entire hip. one of the very first clinical trials, randomized trial in US was actually comparison of the chemical urethane for Coca-Cola for myeloma patients. And perhaps the very first and last time in history, Coca-Cola made people live longer. And we learned a lesson that not to give toxic chemicals and therapies to our patients because they don't live longer with them. Very first time we had actually a bone marrow transplant done for myeloma patients were in the 1960s. And melphalan, as you can tell, is more than 50 years old therapy for myeloma patients, high-dose melphalan. We didn't really have a dearth of drugs, I would say, up until early 2000s when thalidomide and other immunomodulatory agents came into vogue. And really and truly after 2015 and onwards, we saw essentially an explosion of therapeutic armamentarium with 25 plus drugs available now in many different, 50 different combinations for patients with myeloma. Uh, Multiple myeloma is the second most common blood cancer. Non-Hodgkin lymphomas and CLL continue to be the most common heme malignancy in US. The median age in US is 69 years at a time of diagnosis. We diagnose about 35,000 people every year. About 7,000 folks do a bone marrow transplant every year in US, and about 10 to 13,000 actually die with myeloma cancer every year. Back in 2005, when we have about 2 or 3 drugs approved for myeloma, the median survival was somewhere around 2 years. In 2015, when we had more drugs available, it had improved to about 5 years, I would say. And in 2025, as we have this long, exhaustive list of myeloma therapies, we are estimating that a median survival for myeloma patients may be beyond 15 years. Few things about the risk factors for myeloma really is age. As people age, they get exposed to more chemicals, toxins, autoimmune conditions, and infections. And any and all of these can actually trigger manipulation of the immune system and lead to growth and proliferation of clonal plasma cells, where patients develop a condition called MGUS. There is some predisposition when it comes to race, where African American individuals are more predisposed towards it, especially if they are men above 50, and men who have a family history of this. But regarding myeloma journey, I call it a journey of peaks and valleys, or remission and relapses. And that is why we say that myeloma inherently remains incurable. I may tell you a different story in 5 years from now, where perhaps we have devised a strategy with cellular immunotherapy based treatments where we can reliably put myeloma in a deep remission, stop all treatment, and not have it relapse, that we can say that the cure has been attained. But for now, most patients, as they go through their myeloma journey, myeloma chemotherapy, eventually experience a relapse. In historical studies, we have found that maybe 10 to 15% of all myeloma patients can be cured, where they achieve a very long remission. They last maybe 10 to 15, 20 years. And perhaps those patients can stop therapy and not have myeloma return. But it's difficult for us to clearly pinpoint and identify those patients in our practice. We have some testing in the form of a minimal residual disease testing for bone marrow that can sometimes be a guide. But as of now, the ritual is that once you start treatment for myeloma, you continue it as long as it works. Clinical presentation most commonly includes the CRAB criteria with anemia, high calcium, renal impairment, and bone lesions. This was a part of the myeloma diagnostic criteria up until 2014. So before 2014, if you had 10% or more clonal plasma cells in your bone marrow, along with any one of the 4 features, with high calcium, renal impairment, anemia, or bone lesions, you will have myeloma. In 2014, we decided and agreed that there are a group of patients who may not have the CRAB criteria, which means they may not have organ impairment, but still may be a very high risk of developing organ impairment in the coming years. And those patients were the patients who had more than 60% plasma cells in the bone marrow, who had an uninvolved light chain ratio of more than 100, or patients who had an MRI done of their spine and pelvis and were found to have 2 or more lesions, not one, but 2 or more lesions, each being more than 2 millimeter in size. MRI is sensitive enough to detect those. And if they had those features, those 3 features called SLIM, even in the absence of end organ damage from the CRAB, we would call them myeloma and treat them as myeloma. So I'm going to talk about that criteria and share some clinical pearls here with you. So the very first criteria is having 60% or more clonal plasma cells in the bone marrow. If you see that on a bone marrow biopsy sample, on IHC, on core sample, not a flow, because flow is an underestimate usually, we like to call it a myeloma and treat it as myeloma. The light chain ratio criteria is important to remember. It's not kappa lambda light chain ratio. It's usually involved over uninvolved light chain ratio more than 100. But if you see this, you have to have more than 200 milligram of protein being spilled in the urine. So when this criteria was published, actually, if you look at the appendix, you will find that buried in there that patients were required to have organ damage, kidney damage, or kidney excretion of these monoclonal proteins before you would say that someone with a light chain ratio of more than 120 as the only criteria would qualify as myeloma and should be treated as myeloma. So important to remember that. If you see a light chain ratio more than 100, make sure you're testing the 24-hour urine sample. And I'll talk more about this in a minute. MRI with two or more focal lesions. MRI is very sensitive, more sensitive than X-rays, PET, or low-dose whole-body CTs. And if you do an MRI of the lower of the spine area, especially the lumbar spine and pelvic area, it can actually detect focal lesions with hypermetabolic activity better than PET scans and CT scans can. So that's why it was included as well. Calcium levels, remember the corrected calcium levels, not the one that is reported on a CMP or a metabolic panel. You have to correct it for the albumin levels. And if it's more than 11, that would be a criteria. Make sure that you are looking into other etiologies for high calcium levels, such as parathyroid hormone levels and things as such. I do want to say only 15% of all myeloma patients will have hypercalcemia diagnosis. It's usually a feature of terminal end stage myeloma when the calcium levels go really high. So if you see that diagnosis, always look for alternative etiologies. Renal impairment is important, and it usually is defined by a creatinine clearance less than 40. They also say serum creatinine if more than 2 qualifies, but I do want to remind you that I think having creatinine clearance estimation, especially by 24-hour urine sample, is a more accurate reflection of the kidney function because creatinine levels can vary based on a patient muscle mass and some other factors. So I usually look at creatinine clearance less than 40 as a diagnostic criteria. Again, I make sure there is no other reason for the renal for kidney function to be impaired, which means if they have hypertension, diabetes, and very importantly, if they have been taking any medication that can affect their kidney function as well. So make sure that alternative etiologies are ruled out. Anemia, important to remember, hemoglobin less than 10 qualifies, but also more than 2 gram per deciliter drop or decline from baseline. That's a very important point. If you have someone who's a smoker, who lives in the mountains, someone who has sleep apnea, they will have polycythemia. Their baseline hemoglobin may actually be 16. So if they drop from 16 all the way to 13, it will still be normal on your labs, but they have actually met the criteria for this being a myeloma defining event. So important to remember that part of decline from the baseline by 2 gram per deciliter. And finally, bone lesions. If you do an X-ray, if you do a whole body low dose CT scan or a PET CT scan, and you see one or more lesions on imaging that have metabolic activity, they do qualify as criteria again. Let's talk a little bit about the pathophysiology, how exactly all of these clinical features with end organ damage evolve and develop. So by and large, what happens in multiple myeloma is the plasma cells accumulate in the bone marrow. And these plasma cells, as they occupy more and more space, they also release certain cytokines. And these cytokines will stimulate your osteoclast and inhibit your osteoblast. And hence you see more osteolysis, more bone breakdown, more bone lesions, and that eventually leads to a high calcium levels, which can actually damage the kidneys as well. But the kidney damage, by and large, in myeloma patient happens from light chains, kappa, but more importantly, lambda light chains. Kappa light chains can be in the thousands, and still you may see a patient having a normal kidney function, but lambda light chains, once the level goes above 150 milligram per deciliter, somewhere around that, higher than that, you will start seeing that these patients have renal impairment because they're especially nephrotoxic to the tubules. Um, Anemia, by and large, is believed to be a mass effect that the plasma cells accumulate in the bone marrow. They leave the headed space for the other cells, especially the red blood cells, the progenitor cells, and hence you see anemia. It's a mass effect, but also the plasma cells that are in the bone marrow will actually inhibit the hematopoiesis in the bone marrow and lead to some effect of anemia as well. Infections are common because you do see immune dysfunction, immunoparesis, where all of the immunoglobulins are down. Even the IgG levels that are high, they're actually very dysfunctional. So you will see opsonized infections in these patients, especially sinus and lung infections develop. Neuropathy at the time of diagnosis. If you ever see that neuropathy at a time of diagnosis, make sure you're looking into AL amyloid and POEM syndrome-like features. Typically, those neuropathies are different from the neuropathy that you end up seeing with chemotherapy like bortezomib, carfilzomib, and lenalidomide. These neuropathies that you see with chemotherapy agents, they tend to be more sensory in nature, more tingling, more numbness, rather than burning, rather than affecting reflexes, and rather than affecting their muscle activity or muscle or motor strength. Moving on to the next slide, the workup. I'm going to walk you quickly through all of the investigations that we do and why we do them, how we do them, and what we look for. CBC again tells you about hemoglobin. If you have a peripheral smear and you have very high protein levels, total protein levels, you may see some Role formation. It's not what we use to make a diagnosis. CMP will give you an idea about the kidney function. Again, GFR, creatinine clearance. It will tell you about total protein, albumin. Always make sure you are checking a beta-2 microglobulin so you can stage your patients. And always remember, beta-2 microglobulin is useful only if you have normal kidney function. There's new classification, there's no staging coming out that actually will very clearly state that the beta-2 microglobulin is only relevant when your kidney function tends to be normal. Because why? Kidneys secrete or excrete beta-2 microglobulin. So if your kidney function is really impaired, your beta-2 microglobulin is going to be really high. But always check it because it's a part of IS and RSS staging system. We check immunoglobulins for all patients to see which one is involved and which one is parised or paralyzed, as we call it. Serum protein electrophoresis and immunofixation should be done for all of the patients, and serum-free light chains are also done for these patients. I like to do a 24-hour urine assessment at the time of diagnosis for every single patient in myeloma that I see. Why do I do it? Because it actually tells me how much urine is made in a 24-hour sample, how much protein is being spilled, and how much of that protein is albumin, and how much of that protein is a monoclonal or Benz-Jones protein. It has to be more than 200 milligram per deciliter, more 200 milligram in a 24-hour sample for it to be a quantifiable, measurable, and a followable protein. So if I ever see a patient spilling tons and tons of protein, and all of that is albumin, I think of AL amyloid. If I see a patient spill protein and this monoclonal protein more than 200 milligram, I actually like to repeat that again after induction chemotherapy, after 4 cycles, to see how that protein is behaving. If I don't see any measurable protein at all at diagnosis, I actually don't repeat this test. And you will see this come along as well in guidelines that we'll probably stop doing these urine assessment serially for all of these myeloma patients. Bone marrow biopsy should be performed for all patients at the time of diagnosis, and not just a bone biopsy. You may biopsy a bone, a vertebrae, but you should also biopsy the bone marrow to see how much infiltration, disease burden, clonal plasma cells are there on the bone marrow sample. There are 3 different things that we do for those biopsy samples. We look at a core sample, we look at aspirate, and then we run some mutational testing. The core sample actually tells you what exactly is the disease burden. It's based on morphology, how the plasma cells look like under a microscope. It can also be based on immunohistochemical analysis, CD38 positivity, 138 positivity, again, CD56 and CD79. These important markers to look at, and that's how you can sometimes define how much disease burden is there. Remember, normal plasma cells are also seen on a bone marrow biopsy sample. They will not look malignant. They will not have the characteristic immunohistochemical features of a malignant plasma cell, and they will have both kappa and lambda expressed on them. In a clonal malignant plasma cells, you see light chain restriction. You either see a kappa or you see a lambda. You don't see both. So that's important to remember. Aspirate, when you have it pulled out, it's not a good estimate for disease burden because it's almost always diluted. It's an underestimate. So we don't rely upon aspirates to tell us what is the disease burden or how much myeloma is in the bone marrow. We rely upon the core samples. Aspirate tells you whether it's what's the restriction on whether it's kappa or lambda clonal subtype myeloma. And finally, we do karyotype cytogenetics and fish panel. It's hard to find all of the important abnormalities on karyotypic analysis because you don't see a lot of metaphases in myeloma. It's not a very proliferative cancer like leukemias and other cancers. So it's hard to find all of the abnormalities on just karyotype or cytogenetics. So we like to do FISH. And FISH is a test where you only find the abnormalities that you have primed the FISH panel for. Whether it's trisomy, translocations, monosomy, deletions, is only going to pick those particular abnormalities. And there are some few of them that are really important, which I'm going to talk about in a minute. And imaging wise, I like to do PET scans for every patient in my practice because I have the ability, I have the resources to do this. I think X-rays, they miss a lot of findings. You need to lose at least 2/3 of your bone density for the osseous lesions to clearly show up on your X-ray. So even the X-ray is normal, you still want to make sure you do a low dose whole body CT if you have it, or a whole body PET CT scan, because it's really good at looking at not just the bone lesions, the activity, but also it looks at extramedullary disease. And then when we do transplants and things like that, we actually repeat it here to see if the activity has diminished or disappeared with therapy. Moving on to SPEP and light chain. So this is a serum protein electrophoresis, as you can see. Um, so 60% of all myeloma is going to be IgG myeloma subtype with a heavy protein. 20% is IgA, and IgA tends to bury its M spike in the beta region that you can see here, and that's why SPEP may not always accurately, precisely capture the amount of monoclonal protein in a blood sample. So I actually rely on IgA levels on those patients. I think IgA levels, they come back really quickly. They come back within a few hours here, and you can reliably follow them as well as a marker of disease activity response to therapy. So always remember our IgA subtype myelomas that the M spike may be buried in the region here in the beta side, and that's why you should pay attention to the IgA levels as well as you look at the M spike. Um, Very few cases of IgM myeloma. I've actually not even seen one. Usually they're lymphomas, Waldenstroms, LPLs, rather than being myeloma, IgM subtypes. 20% of all myeloma is going to be light chain only. It's either kappa or lambda. And important thing to remember about them, anytime you have a case that you're presenting, that you're getting information on, you're just sending it to the group chat, please remember, mention the units of the light chains. There is a big difference between 100 milligram per liter and 100 milligram per deciliter of light chains. Second important thing to remember, whenever you talk about light chain ratio, don't say kappa lambda light chain ratio, say involved over uninvolved light chain ratio. Because if the lambda is involved and is very high and kappa is very low, your ratio is going to be 0.01 on your labs. That's not an accurate assessment. So I always use the term involved over uninvolved light chains. These myelomas actually respond very well to chemo. The light chains come down very quickly as compared to the SPEPs or the M spikes, simply because of how long the M spike can linger on in your blood or be cleared by the kidneys as compared to the light chains. Let's talk about myeloma risk stratification, staging. DSS system is old. It relied on clinical features. So we came up with ISS and later revised it to RISS, revised international staging system. It relies on albumin and beta-2 microglobulin. And then it looks at the mutations on the FISH panel that you can detect. So we all agree upon this, even nationally, internationally. There are 3 abnormalities which you see them will qualify you as a high risk myeloma. Those 3 ones are deletion 17p, translocation 414, and translocation 1416. If you see gain of 1q as the only abnormalities with no other high risk abnormalities on this list, it's a standard risk myeloma. But if you see gain of 1q with chromosome 14 translocation, like 414, 1416, 1420, if you see it with 1p deletion, it's a high risk feature for myeloma. Anytime you mention gain of 1q, always remember that you have to look at how many of those cells actually had 1q as well. If you're seeing only 2 to 3% of the cells having 1q abnormality, that may not be significant. If you have 2 or more of these abnormalities, you're a double hit myeloma. If you're 3 or more, you're a triple hit. Trisomies are always a good feature. 1114, in my opinion, is a good feature because these patients, they have certain specific characteristics with them. They tend to have more like a lymphoma phenotype. They respond slowly to chemotherapy. Their response are always sluggish and staggered. It's hard to achieve complete remission with therapies, 1114 myeloma, even after transplant. And oftentimes you have to continue them over a longer period of time to see deeper remissions evolve with 1114 myeloma. Always remember, if you have 1114, it's a primary cytogenetic abnormality. This patient had it at the time of diagnosis. And these patients can qualify for a treatment in US at least by the name of venetoclax. Actually use it at the first or second relapse as a therapy, as long as the patients have had 1114 documented, at least at the time of diagnosis. If you don't see it at the time of relapse, maybe your sample was not good enough. If you didn't have it at the time of diagnosis and the patient is relapsing and you think they may have 1114 myeloma, you may want to repeat a bone marrow biopsy and look at a CD138 enriched plasma cells, because those are the ones you want to look at to see if 1114 translocation is there. Again, 20% of all myeloma, They have sluggish responses to chemotherapy, but still get into a deep remission. And venetoclax-based treatments remain an option for these patients at their relapses, second or even if the first relapse. Moving on to MGUS, smoldering, and symptomatic multiple myeloma. So MGUS is defined as serum M spike less than 3 gram per deciliter and less than 10% clonal plasma cells. So does that mean that anyone who has an M spike should get a bone marrow biopsy? No. I actually don't do bone marrow biopsy unless I see high levels of M spike, or if I see that the patient may have some end organ impairment like kidneys, hemoglobin, and things like that. So my threshold for doing biopsies in patients is M spike more than at least 1.5, sometimes even 2 or higher. And patients who have a higher light chain ratio, not even 8, I would say I would usually go by, if there's more than 20 light chain ratio, I would consider a bone marrow biopsy to rule out smoldering myeloma. And what is smoldering myeloma? You have more than 10% or more plasma cells in the bone marrow, but they're less than 60%. And then you have more protein being spilled in your in your blood or in your urine. You have to make sure that these patients do not have any of the myeloma defining event based on the slim crab criteria. It's easy to do it. You can determine a lot of the organ impairments based on simple testing. You need a bone marrow biopsy to see how much plasma cells are there. But hey, this is where the MRI role of MRI comes into play. If you're ever wanting to rule out active myeloma, the best imaging scan that you can actually do is an MRI. MRI of the spine and pelvis. Why? Because MRI is more sensitive. It looks for tiny myeloma osseous lesions. If you have a good radiologist who can read those, and they typically tend to be in the lumbar spine and pelvic region, and it's very sensitive to pick those abnormalities. PET scan can sometimes actually miss those lesions. If you ever see a compression fracture, if you see vertebral collapse, if you see osteoporosis or osteopenia, remember, those are not myeloma defining events. You may want to biopsy that compression fracture or that area of activity on a scan, but unless you find proven evidence on a biopsy of clonal plasma cells, you should not be calling that particular event a myeloma defining event. And finally, we have symptomatic myeloma that we will talk about next. So what do we do for MGUS? In my practice, if I see a patient with MGUS who has M spike, light chains, I like to repeat it 6 months interval just to make sure it's stable. And after that, I do it once a year. Even if you do it once every 2 years, they do that in UK and other European countries, that should be okay. Smoldering myeloma. Anytime I see a smoldering myeloma, I risk stratified a smoldering myeloma into categories based on 20/2/20 criteria. There are at least 4 or 5 different risk stratification model, with the most recent one being called Pangea model. What I do is I still follow the IMWG and a 20/2/20 criteria. And if a patient happens to be a low risk or an intermediate risk, based on that particular criteria, you can find even online, I usually observe those patients. I observe those patients every 6 months or so. I do basic labs on them with myeloma. If it happens to a high-risk myeloma, where they meet 2 or more of the criteria and a 20/2 criteria, I actually watch them more closely. I would actually watch them every 3 to 6 months. There is more recent studies in US that have actually shown that single-agent daratumumab may actually improve outcomes in these patients. I think I offer that to my patients, and by and large, my preference remains to watch. And again, in resource limited settings, I think watching it makes sense for even though some of those high risk smoldering myeloma, as long as you're watching them carefully. One thing I want to highlight very clearly: when I observe these patients with serial labs, anytime I see that the M spike is rising, the light chains are rising, the hemoglobin is dropping, and the kidneys are getting some injury as well, and yet they don't need any clear myeloma defining event, I like to call that entity smoldering myeloma in evolution. I actually treat that myeloma, I treat that smoldering myeloma as myeloma, because I know this is the patient who's going to develop osseous lesions in their skeleton that can be debilitating. So I actually uh, like to treat those patients at some point in time as myeloma, even before they meet the full defining criteria. Because otherwise the risk of having organ impairment, especially the bone damage, is high. Some of the principles of treatment, again, the goal of treatment is control, not cure of myeloma as of now. It may change in the next 5 years. Our goal is to get to as deep a remission as possible, as early as possible. They say with myeloma, your first response is your best response. Your first response should be a complete response. And a complete response is only complete if it's an MRD negative complete response. So we aim for that. We aim for that with whatever therapies we have available. what the patients can actually tolerate, and we like to do follow those particular guidelines, treatment algorithms for those patients. So I'm going to show you what we do at our institution, and I can also give you some idea on how this can be tailored, let's say in Pakistan or resource limited settings where you may not have all these therapies available. So anytime we see a patient with myeloma, the very first thing that I do is that actually stratify the patient based on their risk profile, the beta-2 microglobulin, the albumin, the FISH panel, the PET imaging as a standard risk or a high risk. And once I've done that, the next determination that I make is this patient transplant eligible or not? With a very clear thought process in my mind, transplant eligibility can change over time as well. It can change after 2 or 4 cycles of induction therapy too. But if I make a very clear distinction that this patient, because of their age, their frailty, their medical conditions, or for that matter, their caregiver situation may not be a candidate for transplant, I will call them transplant ineligible and treat them as it is. And this is the schema that we have, or the algorithm that we use at our site and MSKCC. Dr. Usmani reviews all the data after each big meeting, and we actually bring it to our group, we discuss, and then we come up with this treatment algorithm that we use. And I'm going to walk you through this. So our approach to a transplant eligible newly diagnosed myeloma patient is that we stratify them as standard or high risk. We give everyone quad-based therapies these days, which means that we add either DARA, or if ESA is available, we'll do ESA RVD induction for standard risk myeloma. We do about 4 cycles of induction therapy, followed by stem cell mobilization and collection. I like to do upfront transplants for all my patients. I'll tell you why in a minute. And then we move on to give these patients maintenance therapy. If patients are MRD negative, we usually do it by NGS testing. We like to give them single agent LEN, and if they happen to still have MRD positivity, DARA and LEN for 2 years is very appropriate. However, if you happen to be high risk myeloma patients, based on all the risk profile that I discussed and showed you in the previous slide, we actually would replace the bortezomib with carfilzomib, and we do DARA KRD. We do that for about 4 cycles. We offer transplant and actually take a lot of these patients to transplant, especially if they have high risk myeloma. And then again, day 100, we either do DARA LEN maintenance or KR maintenance for these patients. I have had patients who would not want to come in every 2 weeks for carfilzomib, so I give them once a month Darzalex. I would still prefer to give KR maintenance for a double hit myeloma because I think that's where it makes its maximum impact. Anyone who has plasma cell leukemia, bulky EMD, VD-based therapy is very appropriate, followed by DARA RVD or DARA KRD, whichever you want to choose, and consider transplant for those patients. It's been a long time I have seen a tandem auto-allo or an allogenic transplant for myeloma. I think it's because of all the cellular therapies we have available nowadays. And also the very fact that allo transplant has not been a cure for myeloma, despite having all of the side effects and toxicities associated with it. Only about 20% of all patients who go through an allo will have long-term remission. In resource limited settings, I do think still RVD and therapies like VCD will be appropriate, especially if you don't have access to database treatment, as long as transplant is actually a part of the schema, because I think it makes a big difference in those patients. Few important things that I want to highlight here, that we actually only give bortezomib once a week. We don't give it twice a week at all. We only give it subcutaneously, because when you give it intravenously or you give it twice weekly, it's the perfect recipe for peripheral neuropathy. It will not happen as the patient is getting the bortezomib, so we'll not actually be able to capture it. It happens as you finish 4 to 6 cycles, you're about to go into your transplant. These patients will have debilitating neuropathies. Revlimid, I usually like to start off on a lower dose, especially in a quad-based combinations. If patient has high disease burden, you can use higher doses of Revlimid, but you may need to give them growth factor support to support the cytopenias. The carfilzomib dosing, I do want to highlight, we don't give 70 milligram meter square. We only give 56, especially when you're combining carfilzomib with IMiDs, either Revlimid or pomalidomide. Anytime you're doing that, make sure you don't cross above 56, because at higher doses, which is 70 milligram meter square, you do end up seeing more cardiovascular adverse events, and you don't actually get any significant additional benefit by the higher dosing. Moving on to our approach for transplant ineligible myeloma patients. Why are patients ineligible? Because they're old, they're frail, they have medical comorbidities, they may not have a caregiver, and hence you think that they are not really eligible for transplant. And those patients, you may want to consider not doing transplant and just doing therapy until disease progression. So if it's a frail patient, truly frail patients, we give DARA Lendex, and we actually continue the DARA Lendex until disease progression. If a patient has strong preference for not continuing LEN, you can do DARA monotherapy as well eventually once we have had 12 months of treatment. But we like to continue DARA-LEN until disease progression in these patients. If they happen to be a high-risk myeloma, DARA-LEN combination, we continue until disease progression. If you happen to have a transplant ineligible patient who otherwise is fit or intermediate fit, I think DARA-RVD or ESA-RVD are a reasonable option. They have been shown in more recent trials to be very effective. We like to do it for about 6 cycles. And after 6 cycles, we peel off the bortezomib and continue the patient on DARA-LEN-based maintenance chemotherapy. Again, if you don't have access to DARA, RVD and VCD may be appropriate. My philosophy is that IMiD-based treatments may be better than alkylating agents like Cytoxan. So even if I have a patient who's on Cybo-D because they have renal impairment, we don't have access to Revlimid, eventually I would like to transition them to RVD or DARA-RVD to get adequate disease control. What's the role of bone marrow transplant, or why do we call it a Tom Brady of myeloma? This was a large randomized controlled trial done in US, started in 2010, eventually presented in 2022, that looked at upfront versus delayed transplant. Let me explain this for a few minutes. So in this particular trial, we had patients with newly diagnosed myeloma, and we randomized them into 2 groups, with the early transplant group getting high-dose chemotherapy, autologous transplant after 3 cycles of induction. In comparison, the late transplant group got induction therapy, collected stem cells, but went on to get 5 more cycles of RVD before transitioning to lenalidomide or Revlimid-based maintenance chemotherapy. They only went through a transplant at the time of relapse. Again, if the physician and the patient agreed upon doing a transplant for a relapse. And what we learned from this particular trial is that when you do an early versus a delayed or transplant at the time of relapse, what you notice is that the progression-free survival is better for patients who go through an early transplant. This progression-free survival difference is significantly important when you look at high-risk myeloma, where you only get about 18 months out of RVD alone approach, and these patients relapse. So I think a high-risk myeloma, it makes a huge impact on the PFS. There's still no difference in overall survival that is seen, and there may be many different reasons for it. But I still think that upfront transplant is a very important tool and perhaps the best route to take a patient into a deep and durable remission in resource-limited settings where you don't have access to therapies like carfilzomib or daratumumab that you can use for induction or for maintenance purposes. So I do think transplant is a great tool in the toolbox in resource-limited settings. All high-risk patients in my practice, I strongly encourage them to go through transplant. There's no overall survival benefit. That may be because it's hard to see that benefit in a cancer that has median survival beyond 15 years nowadays. Secondly, there may be one that may emerge over longer follow-up. I do like to do early transplant because I think many patients over a period of time grow older, may not have the ability to go through a transplant or have a caregiver, have more comorbidities, may not have the ability to even collect and store stem cells. The only time I may actually not do transplant if I have a young patient who has standardized myeloma, who has done very well with their induction therapy, and they have a very strong reason, very legitimate reason to actually collect and store stem cells for perhaps a future transplant. And those patients, I would be in agreement with the patient if that's what their strong desire continues to be. Maintenance therapy, we usually do it after transplant, starting day 100. In our practice, we do LEN for everyone and do add DARA to it if they are MRD positive on day plus 100. But I think LEN alone is a very appropriate option. If you do RVD induction, followed by transplant, followed by LEN maintenance, which is very doable anywhere in Pakistan if you have access to transplant, it usually gets you 7 years of remission. And I think it should be continued until disease progression. Having said that, there are trials going on in US. We're doing time-limited maintenance for about 2 years with LEN and DARA-LEN-based options. And at the end of the 2-year mark, the patients are in a deep remission, MRD negative remission. They are randomizing them to stopping all maintenance. The trial has actually completed its accrual, but I think before its results are published and we know what happens to these patients who stop all maintenance after 2 years, it'll take us another 4 or 5 years before we actually know all of the results of this particular trial. So for now, LEN maintenance until disease progression, and DARA plus LEN combo, usually we do that for about 2 years for patients who are still MRD positive. Some complications of myeloma and its management, hypercalcemia again can be seen at diagnosis in about 15% of the patients. Is commonly seen at heavily pre-treated relapse refractory, especially penta-refractory myeloma. How do you manage it? Give hydration. You can give Zomata, and you can repeat Zomata actually every 2 weeks in some of these patients. You can give Xgeva as well. In very high calcium level, if you have access, you can try calcitonin. We usually do it every 12 hours for 4 doses. It is expensive. It can be restricted sometimes, but again, fluids and Zomata are cheap and can be done. In my experience, high dose dexamethasone can be a great remedy for hypercalcemia because it reduces the myeloma tumor burden, especially when you're newly or freshly diagnosed. Cord compression can be seen at diagnosis as well from myeloma bone disease and even at the time of relapse. Again, we give high dose dexamethasone. We like to radiate that area. We do call neurosurgery services for evaluation, but oftentimes it may not intervene in these patients. Always remember the symptoms of cord compression before you actually consider radiation therapy, or for that matter, any neurosurgical interventions. Renal failure can be seen in about, I would say, impairment can be seen in about 40% of the patients at a time of diagnosis and at least 20% at a time of relapse, I would say. And if you ever see that, make sure that you're ruling out alternative etiologies. You're ruling out diabetic nephropathy. You're ruling out uncontrolled hypertension causing renal impairment. Very common reasons for myeloma patients to have renal impairment is actually use of ibuprofen, Motrin, and Aleve. They can actually damage the kidneys as well. And when you hydrate these patients who have been dehydrated, malnourished, you may see improvement in kidney function. Having said that, most common reason for renal failure in myeloma patient continues to be myeloma cast nephropathy, which means very high levels of kappa light chains and even levels above 150 with lambda light chain. If I ever see that, my first response to that is starting chemotherapy while the patient is admitted. Bortezomib dexamethasone, in this particular case, twice weekly is very, very reasonable. You can give pulse dexamethasone, 40 milligram for 4 consecutive days, along with a twice weekly bortezomib. And then I think time is of essence. So I usually like to even plasma freeze these patients when light chain levels are so high, along with the chemotherapy to salvage their kidneys. Your ability to improve renal function largely depends upon how quickly do you intervene after seeing those patients. So time is of essence again. Myeloma bone disease is seen again in 70% of all folks at a time of diagnosis. For pain control, again, dexamethasone can be very helpful early on while the patient is admitted. Chemotherapy eventually helps, and then kyphoplasty is something that we considered in these patients. Um, you can do radiation therapy and you can do kyphoplasty in these patients. Usually we like to sequence these procedures, and all of these patients who have bone disease should be getting myeloma bone modifying therapy. And what is that? Is Zomata or Xgeva. One may be more expensive than the other, but they have very similar outcomes. Zomata is cheap, is usually given intravenously. I like to give it once a month, every month during induction. And then I also do it post-transplant for 2 years. During the first year, I would give the bone modifying therapy every month. But beyond a year, you only need to give it for about every 3 months. You do it for about 2 years, and a patient is in deep good remission, VGPR or better. You don't need to continue it beyond that. We always make sure that we get a dental evaluation and clearance, because if you have Zomata or Xgeva given to a patient and you perform dental extraction, you can notice necrosis of jaw and complications as such. So we try to avoid that. Any patient who gets myeloma bone modifying therapy, Zomata or Xgeva, we like to make sure that their vitamin D levels are adequate, especially if elderly females will be vitamin D deficient. You give them Zomata or Xgeva, and you can end up with protracted, prolonged, resistant hypocalcemia, where you have to give them calcium gluconate infusion periodically. So make sure you're checking vitamin D levels in all of your patients with myeloma before you start a myeloma bone therapy. Um, Infections again are common, and especially with CD38 based antibody treatments, it can happen. So we give antimicrobials, we give IVIG to these patients. I don't typically use a lot of fluoroquinolone prophylaxis for neutropenia. I don't think it's always indicated. I would rather give them GCSF and dose modify my Revlimid and other chemotherapy than keeping these patients on fluoroquinolone prophylaxis. I don't use Bactrim with daratumumab. I know it comes in the package insert with the daratumumab, but I don't usually actually use the Bactrim. I think it can affect blood counts and kidney function as well in some of these patients. And then I have not really seen from the frontline myeloma developing PJB as long as there's a time-limited induction therapy. Vaccines are important, I do believe, in patients with plasma cell disorders. They may not react very well. They may not respond very well to the vaccine. You may not see the titers rise, but again, there is value in giving these patients, giving the benefit of the doubt, and giving them COVID vaccines, flu vaccines, RSV vaccine nowadays, for these patients. Some of the side effects, and this is more clinical pearls of wisdom that I'm sharing, that you may have seen patients who are at emits, Revlimid, Palmolid, they get cramps. The cramps happen at night time, usually affect your hands and your feet. Sometimes can even affect your belly, the muscles. And the solution for that is actually giving them tonic water. That's one. But pickle juice can be very helpful. And there are mustard, some of my patients actually carry mustard pockets. They mix them with water and drink it, and that can actually really help relieve some of these cramps. You don't necessarily need to stop chemotherapy or dose reduce chemotherapy for that reason. As long as you try these remedies, you may see an improvement. Neuropathy is very common. The recipe to neuropathy is bortezomib twice weekly or intravenous. No one in this country gives IV bortezomib. Everyone gets subcutaneously. I strongly advise not giving twice weekly bortezomib. I would say once a week is good enough. And if in case you do develop neuropathy, then there are some neuropathic medication that you can try. There's some massage therapies that you can do. Some of our patients go acupuncture as well. But there are some YouTube videos actually that actually show you massage therapy on hands and feet that can be helpful for some of the low-grade neuropathies. Two-thirds of the patients develop neuropathy, and usually half of them only recover from it. The other half continue to have this neuropathy affect them. Fatigue is very common, and we do recommend yoga, exercise, swimming, walking to these patients to help counteract some of the fatigue. Again, Revlimid will cause some taste changes, dysgeusia, or altered metallic taste, and things like that. And I tell my patients, try eating something that you've never tried before. If you really liked something hot and spicy, try some cold and sweet. Uh, Sometimes you do lemon as well, lemon drops and lemon itself to actually help stimulate some of the taste to come back. Moving on to relapsed myeloma, I have about 15 minutes, so I think I'll quickly move through this. Um, it's the Cheesecake Factory menu. There are 25 drugs, 50 combinations. It's not easy to pick from them, but there are certain principles that we apply. The very first principle is, do all patients with relapsed myeloma need change of therapy? No, the answer is no. So if you have a patient who has standardized myeloma, who has a long durable remission, now they're slowly seeing an indolent biochemical progression, you can increase the dose of the maintenance, maybe add some steroids to still recapture control. Having said that, if you had a high-risk myeloma patient that relapsed early on maintenance therapy or after transplant, I think it's time to switch therapies on those patients, because from biochemical relapse to clinical progression with bone disease, hypercalcemia, organ impairment is usually 6 months. So you do want to intervene with change of therapy. We like to switch all classes of therapy. If a patient has that exposure to data before, but then they did not get it for maintenance, and they are not refractory to it, you can still use data-based combination for these patients. Again, it depends on what exposures they have had before, what toxicities they have had. I still think the VCD remains an option in resource-limited setting for these patients. I think Dara-Palm-Dex is very appropriate as long as you have at least 2 or more years of remission on LEN-based maintenance. If you're progressing within 2 years of your transplant on LEN-based maintenance, I think the way to go would be Dara-KD or ISA-KD based therapies for those patients, because they don't get long-term remission with Dara-Palm-Dex. Pentaclast refractory myeloma, I'm going to briefly touch upon it. It's more of a question and concern in US. CAR T versus bispecific, how do we pick and choose? Before I say that, I think pentaclast refractory myeloma has poor outcomes. Outcomes are better when you pick BCMA based therapies like ADCs, bispecific CAR T, rather than traditional chemoimmunotherapy. And there are multiple different bispecific antibodies that have been approved as monotherapy, now studied in combination therapies. That have shown very good outcomes. As monotherapies, they are actually getting us response rates of 70%, and they're lasting anywhere between 12 to 18 months in heavily pretreated relapsed refractory patients. That is why we're combining them together. We're moving them in the frontline settings. We're actually doing time-limited therapy as well for patients who would achieve deep remission in these particular circumstances. CAR T has been approved in US for 4 or more prior lines of therapy, but more recently, I would say about a year or so ago, it has been approved in earlier lines. So cilta-cel being given to a patient at first relapse, ida-cel at second relapse, and now we are doing trials, moving it upfront and doing it in comparison with transplant to see if it's any better than transplant for standard and high-risk myeloma patients. So you can see clearly how it's making its way all the way in the frontline therapy, and that's perhaps the way we will one day cure myeloma. So some clinical pearls of wisdom, I'm going to share them quickly here. I think this is perhaps the money slide, I call it. It's all of the clinical pearls, important things that you need to remember, whether you're in US or in Pakistan, on what you should be doing when you see myeloma patients. The very first one is, just always make sure that you're ruling out alternative etiologies for anemia. Patient can be iron deficient because they're bleeding in their gut. So make sure you check iron stores and things like that before you blame the anemia on myeloma. Myeloma-related anemia is by and large a mass effect. So if you have, let's say, 10% plasma cells, your hemoglobin should not be 8. There is another reason for that to be low. However, if you have 40, 50, 60% or more plasma cells, yes, you will have a hemoglobin of between 8 to 10, and that is a myeloma defining event. Similarly, if you have renal impairment, make sure that the patient doesn't have another alternative etiology, like they have bad diabetes, hypertension, they have been taking medication like NSAIDs, ibuprofen, Motrin, which as you hold therapy gets better. If they're dehydrated, you hydrate them, and a kidney concentration goes from 5 to 1, creatinine goes from 5 to 1 in a 24-hour time. That was dehydration rather than myeloma. Check light chains in those patients. If they are normal, that's not a myeloma defining event. X-rays, again, they're not always reliable because you need to do significant bone density because X-rays will show you lytic lesions. So absence of evidence is not the evidence of absence. So if you really are in doubt, you should do a low dose whole body CT scan and look for lesions. That can be without contrast. If the patients have bad kidneys, you don't need contrast for these lesions to show up. High-dose dexamethasone can be used to relieve pain, hypercalcemia, renal injury during workup. Let's say you have a patient who comes into the hospital and you think they have myeloma, you're doing your workup, you performed your biopsy, now you're waiting some results to come back, give them high-dose steroids. 40 milligram for 4 days can actually really bring down the protein levels and light chains. If they're bad kidneys, they may also improve as well. So it's cheap, it's simple, it's easy, and it can help you with some of these complications. Again, very importantly, kappa light chains can be very high and still not necessarily cause cast nephropathy. Having said that, lambda light chains, they are particularly nephrotoxic. And if you see high levels of lambda light chains, more than 150 milligram per deciliter, you should get concerned. If they have bad kidneys with that, you should try to treat them ASAP and also consider plasmapheresis because, again, time is of essence here in these patients. Whenever you do a bone marrow biopsy, get a FISH testing on these patients. Karyotype may not always capture all the abnormalities. Rely on the core sample, not on the aspirate for how much disease burden is there, because aspirates are usually an underestimate. Anytime I see a lambda subtype myeloma, regardless of what the heavy protein is, I usually also stain for Congo red. I throw the Congo red on the bone marrow sample and see if it's staining because you want to make sure there's no concurrent AL amyloidosis along with the myeloma in these patients. RVD, I still think is appropriate in resource-limited settings, although in US, we do quads, there are RVD. Do not give twice weekly Velcade. Do not give IV Velcade. Dose is just your Revlimid based on cytopenias. If I have a patient who is elderly, who's frail, who's above 75, I would never give them 25 milligram of Revlimid 21 or 28 days. Actually, would start off with 10 and keep it there. Maybe increase it to 15 in some patients, but by and large, for elderly frail patients, I usually only give 10 milligram of Revlimid 3 weeks on, 1 week off, because they don't tolerate 25 milligram very easily. Similarly, dexamethasone, there's some new studies coming out from Europe actually telling us that dexamethasone is really not needed beyond 2 cycles. So if you have a patient who's elderly, who have diabetes, who have complications, you can actually stop all dexamethasone after 2 cycles of frontline therapy and not have to continue. The only time I may continue it if the patient is still having some reactions to DARA or other things, but other than that, actually you can discontinue dexamethasone after first 2 cycles. Always do adjust your dexamethasone. Anyone who's above 75 should get only 20. Anyone who's less than 75 can get 40. But if they're having side effects, drop the dose. From 40, go to 20, 20 to 12, and make those adjustments. I still think high dose therapy, autologous transplant is a very important treatment tool in resource limited settings. That is the way that we, for our patients in resource limited settings, can get a very deep and durable remission. On average, 7, maybe longer years for many of these patients without having access to DARA or carfilzomib-based therapy, or even CAR-T for that matter at the time of relapse. So I think this should be explored for all of these patients. And we continue LEN until progression for all patients. And if you have access, you can do DARA and LEN for MRD positive patients, but you don't always have to do it. I still am perfectly fine for my patients who have MRD positive disease and they don't want to come in for DARA injection. I give them LEN maintenance, but only 10 milligram. I don't do 15 milligram or 20 milligram per minute. That's not a dose. So 10 milligram is the dose for these patients. You can do LEN and bortezomib for high-risk myeloma. Again, bortezomib is cheap. You can give it subcutaneously every 2 weeks. You can do it for 2 years or so and see how they're responding. And if they want to continue. Otherwise, you can stop after 2 years and only do LEN. And then again, the only time I would actually stop all maintenance is if I have had a patient who has a remarkable response, standard risk myeloma, went through a transplant on LEN maintenance at least 2 years, and they're having debilitating side effects. And they're wanting to stop treatment. I would do a bone marrow biopsy, do an MRD assessment by NGS panel, make sure they are negative before I stop it, and then watch them closely with blood work and biopsies yearly on yearly basis with MRD assessments. Check vitamin D levels before you give my bone modifying therapy. Avoid giving Zomato or XG1 renal failure patients. If you have someone on dialysis, you give those medicine, give those therapies. you can cause more damage. You can cause significant hypocalcemia in those patients. And you don't need to continue these bone therapies beyond 2 years because, as long as they have good control of their myeloma, you don't need to do it. And again, if you have relapse disease, indolent relapses, you can watch it. If they have slow rise of protein, you can increase the dose of Revlimid, add some more dexamethasone to recapture control. Second transplant is falling out of favor in US. Why? Because you have access to CAR-T. I still think there's a role in resource-limited settings that if you have stem cells, patient is young, have good function, and they got somewhere around 5 years from the first transplant, I think it can be a great option for those patients to get a second durable remission. I only have 5 minutes left, so I think I am going to very briefly talk about amyloidosis. There are a few things that are important to remember. And we all know it's a protein deposited on body organs. That can lead to it. The one that is important for us is AL amyloid. It can exist as its own entity. For every 20 myeloma patients, I see one AL amyloid. So it's rare disorder to begin with, but it can be seen with myeloma as well. And it's important to look for it when you see a lambda subtype myeloma that may have odd features of significant weight loss, neuropathy, nephrotic-rich proteinuria, and cardiomyopathy, as you can see here. When we see a patient, what are the times that you should get concerned about AL? Let's say you have benign hematology or a hematology clinic and you see everything. Be on the lookout for these particular warning signs. The most important one being, if you have a nephrotic range proteinuria, more than 4 grams of 2.5 grams of protein spilled in your urine, and you don't have uncontrolled diabetes or hypertension, look for AL amyloid. If you have a patient who has heart failure symptom, concentric LVH on an echo, and they're non-ischemic, look for AL amyloid. High alkaline phosphatase, big liver, look for AL amyloid. Painful burning neuropathy with motor impairment, motor dysfunction, and autonomic dysfunction, look for AL amyloid. How do you look for it? SPEP, UPEP, light chains. This is the very basic test that you can run on these patients and see if they have any monoclonal protein. But once you have it, you should go after the involved organ, kidneys or heart or any other of those organs that are involved, and get a biopsy, because you can see MGUS coexist with diabetes and hypertension and heart failure as well. So it's important to not just show the presence of a monoclonal protein, but in fact, also the amyloid and AL amyloid on testing. And usually do that by laser microdissection. Therapies, I would say Dara-Cybo-D followed by Dara maintenance for 18 months is the standard of care in US. If you still don't have access to Dara and you want to use VCD, I think it's very appropriate. 6 months of therapy can get you into depressions. I do think, again, transplant is a great resource. 100, but in US is falling out of favor again because we have such. This is a group of myeloma physicians that I work with. Dr. Usmani is our service chief. We have a very robust group. We see patients from patients who need a second opinion from other countries, if it's Pakistan or India or other places. They come in and see us. And anytime if you need any help or are looking for an opinion or a consultation, feel free to reach out. You can send an email, a message. We are here to help. Thank you so much for your time.
This was a fantastic presentation, Hamza. I personally learned a lot of good information from this lecture. And I was trying to field the chat section. I was trying to field the question answer. So I tried to address those. So let's see if there's any pending question left for us. And as you know, now we probably need a full lecture on the relapsed refractory myeloma and a full lecture on the amyloidosis, because this is probably not a justice to just talk about these things in few minutes, because there's so much to talk about. But I think we'll continue to, rotate different topics and come back. I think there was a question I couldn't really understand, and that's probably not related to myeloma. There's an 80-year-old patient, a new diagnosed case of DCLD features, having cytopenia secondary to hypersplenism. How to treat such patients? So I actually admit that I do not understand the question properly. There was a question about tandem transplant. I think you touched base about that. If you can do it, do it. I must say in the US, doing single transplant is more standard because at the back end, we have many other good options available. Allogenic transplant is not considered a standard approach at this time. If you have a clinical trial, that's where you can do auto followed by an allo or an allo transplant. but it's not routinely done. It's not considered a standard approach for multiple myeloma. We have now clinical trials going on for autologous CAR T as well as allogenic CAR T. So we have access to those modalities here in the US.
I think there are a lot of comments in the chat box, so we may not be able to address all of them.
Correct. Yeah, no, I think those are mainly introductions. Are their feedback? How did they think the lecture was delivered? And it's mostly appreciation. Um, what is DCLD? Do you know?
I'm not sure if some sort of if it's a plasma cell disorder that we are looking at, if it's a light chain deposition disease, but even the acronym does not sound familiar to me.
Yeah, it's not
Um,
something we commonly use in our routine day-to-day lingo here. Decompensated chronic liver disease and hypersplenism. That's
I see.
probably, yeah,
I
yeah,
see. So I
that's
think
that probably
that's a good one,
so.
actually.
Yeah. Okay.
I think that's a good one. So if you have like elderly patients, very elderly, very frail patients, I think giving them single agent data is very effective. Low dose dexamethasone for those patients, especially. The question comes of whether you give bortezomib or lenalidomide. For a cirrhotic liver, bortezomib is difficult to give because it can have significant toxicity from not being cleared. Low dose len can still be given as long as they don't have significant cytopenias. I would say 5 milligram only, or 2.5 milligram even. Having said that, single agent data can actually still be effective in those patients. So I would say start off with data, control the disease, have the counts get better, and then maybe introduce a low dose len, 5 milligram, 21 or 28. Don't give 25 for this patient. Bortezomib is going to be difficult in a cirrhotic patient.
Right. And I'm not sure that this was in the context of patients having multiple myeloma and on top of have a liver disease and a need for treatment. So let's assume that's a scenario. I think the time is up. Fantastic job. Once again, thank you. We look forward to have you come back again in the near future as well. And we'll
Thank you so
share
much
the
for the
results
opportunity.
with everyone. Thank you.
Have a good one.
All right. Goodbye.